Hi everyone, this is Neel Raithatha, consultant, audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral fully occluding earwax, and I'm just commencing with their right ear first. This is the worst ear out of the two. In fact, this is the ear that the patient presented symptoms with. Although their left ear was also blocked, they were asymptomatic until I removed this and cleared their right ear. They've got really soft, stodgy, glutinous wax, and hence why I've installed some medical grade olive oil spray. And what the olive oil tends to do with this type of wax is kind of bind it together, coagulate it. It also helps to lubricate the canal walls, so there's less friction as I'm bringing this wax plug through. And it also lubricates the inside of the suction tube, so if there's wax traveling up and it gets trapped, the oil will help it move along. Now, I'm working in a region called the isthmus. Now, an isthmus is a medical term given to a narrowing. And we have two narrowings in the ear canal. The first one is in between the first and second bend, and you can just see the first bend to the left where the hairs are protruding out on the left-hand side. And then the second bend is about a further ½ centimeter into the ear canal. And that part of the ear canal is quite narrow in comparison to the canal beyond that. And if this wax plug is extending all the way to the eardrum, it's going to be a lot larger, deeper in the ear in comparison to the entrance of the ear canal. So it can be a bit tricky wriggling through. It's better with softer wax because as you're bringing it through, you can kind of almost squash it into a smaller piece. But to help in a moment, I'm going to use the Correct. Now, I was hoping that the Correct will remove this as a singular plug, but it was just too soft, so it broke it down into smaller pieces, which is fine because by defragmenting this wax plug and reducing its size, it's going to then make it easier for me to bring it through that isthmus. The problem, however, with this type of wax when you use a Correct is that you can somewhat smudge it and smear it against the canal wall, and that did happen, but it was an easy fix. I just reverted back to microsuction and I was able to remove that. So on this occasion, I'm going a bit deeper into the ear canal and I'm just leveraging in behind it. As I'm coming away with the Correct, we've got to be very, very careful that we don't scratch or graze the bottom of the ear canal with the tip of the Correct, which can quite easily happen actually. So again, I'm just going to remove this wax in that isthmus region, and now I'm going to revert back to microsuction. I'm just stretching open the ear. Because the outer third of the ear canal is made up of cartilage, it has got some maneuverability, so we can dilate that portion of the ear canal. As we delve deeper into the ear canal, into the bony part, of course, because that's rigid, we can't manipulate that, we can't stretch or straighten the bony part of the ear canal. And because it is a bit smaller, it's still putting up a bit of a fight, mind you, but I do succeed in bringing this out of the ear. It didn't come away in one singular piece, it broke away because it's quite soft and because of the narrowing, so there is some residual wax on the eardrum and on the front section of the ear canal, which you'll see in a moment. And it's important with this type of wax that when you're performing microsuction, not to fully submerge the suction tip into the soft wax because it will just block it, and it did happen to me on a couple of occasions. So you somewhat have to hover over the surface and kiss the surface with minimal pressure. So I'm just going to the bottom, I'm leveraging it upwards, and I'm just now going to slowly bring it away, hopefully, and meander around the bendy section of the ear canal that I described earlier. So I've got a good suction grip and giving it a good wriggle now, and I've managed to bring that away. So we're going to re-enter the ear. I'm going to dilate the ear canal entrance. I'm going to get this deeper wax in focus, and we're also going to increase the brightness so it's more illuminated. We can see the posterior section of the ear canal, and you'll have another opportunity, but you'll see this white rim around the eardrum, and we call that the annulus. And it's made up of fibrocartilage, and the function of the annulus is to keep the eardrum somewhat in in place, but also to stretch the main body of the eardrum, the pars tensor. And it's important that the eardrum in that region, the pars tensor, is stretched because it makes it taut. And when it's taut, sound waves can vibrate against the eardrum, and these vibrations are then transmitted through the hearing bones, the middle ear bones, also known as the ossicles, the hammer bone, the anvil and the stirrup. And this mechanical energy is then transmitted to the organ of hearing, the cochlea, where it's converted into electrochemical energy, which then travels up the hearing nerve, the auditory nerve, to the brain, where it's processed and interpreted as sound. So they have got a slight attic retraction. The top part of the eardrum on top of the hammer bone is somewhat sucked in, but there's no keratin buildup there. Now, there is some crusted wax here. We have zoomed in here, and you can see the level of detail. And I thought, if this comes away with minimal resistance, I'll try and lift this off the canal wall, but it was slightly crusted, and because we're so deep and on the bony part of the ear canal, I decided to leave that. I'm not going to risk scratching or abrasing this, or lacerating even the canal wall or the eardrum where still over some wax that's not really going to affect the patient. Now I'm just getting the eardrum in focus. You can actually see the texture of the eardrum. You can see some of the fibrous tissue that's contained in the middle layer of the eardrum. So the eardrum has three layers, and the middle layer is made up of fibrous tissue. The outermost layer of the eardrum is made up of the same skin that lines the inner 2/3 of the ear canal, and the middle layer of the eardrum is the mucosal skin layer, which also lines the middle ear. So mucosal skin cells are secretory, and you can compare it to the skin that lines the inside of your nose and your mouth. So as soon as I removed the wax from their right side, they noticed their hearing loss on this side. It became more apparent to them. This wax is somewhat a bit dry and firmer, so I didn't have to use any oil in this ear, and it wasn't as deeply as impacted. Now what I'm doing here, I'm just working off the floor of the ear canal, trying to separate and loosen this from the inferior canal wall, and there's some dry crusted skin here which is also enveloped around this portion of the wax plug, so I'm just trying to separate and elevate that as well off the canal wall. And once I've mobilized it, then I'll try and remove it. When I first started performing earwax removal, I would just go to the center and just trying to suck it out. But there is steps and processes, and or if you've got really dry wax like this, or even in the case of the right ear when it's quite soft and glutinous, trying to lift it off the canal wall first, free the plug, and then bring it away. So I've managed to free this plug, and now I'm just trying to wriggle it through and out of the ear. So again, it's trapped in that region called the isthmus, in between the first and second bend. So I've just gone back in with the specular. I'm just further dilating this ear canal. And on the right hand side, that's the first bend, because you can see those hairs protruding outwards. And I've got a good suction grip here, so I'm slowly now teasing this through, and it's more or less come out in one piece. So I'm just going to visualize the eardrum, just increase the brightness, going to get it in focus. That's the hammer bone that you're seeing. Unlike the right side, there's no attic retraction there. And you may have noticed deeper in the ear, it's quite narrow. And you can't fully visualize the anterior recess, which is normally the case whenever you use, other than an endoscope, in a very narrow bendy ear canal, it can be difficult to visualize that region of the eardrum. So there's just some dry skin here near the entrance. So whilst we're here, we're just going to peel this away. And they also had it in the right side, but near the entrance, the ear canal, they've got this valley, and there's accumulation of dead skin here, which I'm just peeling away. So this skin has failed to migrate because of that valley, and it may be the underlying reason as to why this patient suffers from chronic wax impaction. The wax is trying to come out, and the way the wax comes out, the wax sits on the skin that lines the ear canal, and that skin is a conveyor belt. It's constantly replacing itself, and as it is, old skin travels outwards laterally towards the entrance of the ear, and it transports any earwax sitting on the entrance also out of the ear. So I'm happy with that. I'm going to visualize the eardrum again. So it's extremely narrow there. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.